Coffee with Coker is a healthcare business podcast from the Coker Group that focuses on solutions to help healthcare organizations effectively navigate the changing healthcare industry landscape.
Welcome back to another episode of Coffee with Coker. We will be continuing today our Physician Enterprise Performance Improvement series. And today's session is focused on patient access and throughput. And we're going to go around the table here. This is Brant Jewell, Senior Vice President. We also have Kelly Raffel, Senior Manager, Andy Sobczak, Senior Manager, and Baines Welch, Senior Associate. We're going to talk about things that we're seeing in the market, our experience with clients, and some of the ways that we like to think of both patient access and throughput, and not necessarily thinking of them in the same fashion, but we'll tie that back as much as possible to areas of operational and financial performance. And sometimes they get separated in the minds of health system leadership and physician enterprise leadership, but we see them as very much correlated, and it's in lockstep with some of the items we've already tackled to help improve revenue. So, patient access is often thought of in terms of patient satisfaction, right? Can patients get through on the phones? Can they get an appointment when they want to? And how long is the wait time? And that is relevant, and it is patient access, but patient access as a performance tool is more than that. And I would argue that the patient satisfaction side of the equation is more about maintaining or increasing your demand in the market than it is about keeping a patient who's already on your schedule happy, or someone who wants to be on the schedule happy. And so, again, very correlated, but today we're going to focus as much on how patient access impacts productivity and operational performance as we do the softer side of consumer satisfaction. And one of the areas that is very much impacting access is staffing. And that's both provider and non-provider. Everyone is struggling with staffing on the non-provider side in particular. We've seen provider exodus as well, but organizations usually fill this bucket last, whether that's front office or call center or others. And when you can't find people to answer the phones or check patients in or make outbound calls for reminders, then you see gaps in schedules. You start having more no-shows. You start seeing rescheduled at the last minute. And your expense doesn't necessarily go down if you're paying a higher price for what you used to in those same roles. Compounding that is physicians and providers and their availability. As we continue to see increased patient demand and physician shortage that you've probably read about in some form of media, it's going to require that the future not look like the past when it comes to managing access. There are a number of tools and ways to augment your ability to manage patient access and communication. We're going to talk about some of that today and how you can best adopt or select or utilize some of those to get the most out of it. I think to date, we've seen a lot of clients struggle with trying to buy a solution and fit it into what is a traditional form of scheduling, handling phone calls, handling triage, and the tools aren't necessarily built that way. And so I think the paradigm shift we're going to have to see is not managing our schedules, not managing call centers and outbound and inbound patient communication the same way we have over the last 10 years for the next 10 years. And so what in your unique scenario can you do to best manage all of those different dynamics between provider issues, staffing issues, your technology, your phone systems, all the things that contribute here to fill up schedules, make it easy for patients, keep satisfaction high, and ultimately fill more slots with more satisfied patients that helps your revenue and helps create even more demand for your health services. So with that said, I'm going to pass the mic here over to Andy and let him talk about some of the things that we're seeing from a trend and market perspective as it relates to patient access.
Thanks, Brant. Relative to the market, and when we talk about the market, maybe more so just focus on like health systems. There's a report that comes out annually from the Center for Connected Medicine and Class Research. It's called Top of Mind for Top Health Systems. And in 2023, the three topics that rose to the top of mind for the top health systems were patient access, telehealth, and artificial intelligence. Those three topics were also the top three topics in the previous year's survey. And so that tells you that patient access isn't going anywhere and remains a concern for the largest health systems in the country. It makes a lot of sense because Brant mentioned, a lot of information coming out about looming physician shortages. More specifically, addressing that, there was a recent study that was circulated from Definitive Healthcare that showed about 145,000 healthcare professionals leaving the workforce in 2021 and 2022. Of that 145,000, about half of them were physicians. And the physician shortage has been talked about a lot. And, it's driven by a lot of factors, but you look at the aging population and the demand for care. We're getting older as a country, and that's going to continue with baby boomers getting into that retirement age. So the need for services for that group is going to continue to grow. But also you have disease prevalence in areas like cardiovascular disease, orthopedics issues, things of that nature. Demand in those areas is exploding. But at the same time, you have the physician population that's caring for those patients dwindling. There are fewer residents coming out than there are retirees. And so, kind of on average, you look at another study from the AAMC that essentially said that about 50% of the physician population is over 55 years old. In some specialties like orthopedics and cardiology, that's closer to 60%. And so in the next 10 years or so, you're going to have a lot fewer physicians to care for a much larger population. And so there are definitely strategies in patient access that are going to be relevant to address that. We frequently talk in healthcare about doing more with less. That is just as true in this area as every other area, from expense management and on and on. And so, what we're going to discuss today and what we think is more important now than ever as it relates to patient access is how efficient are you at managing it? How easily can providers get through the day? Can they get through the day treating more patients? Are they using additional staff or technology to do that in an easier way? Because of course you don't want to burn out these precious physicians that are, shrinking in size in the country, and it's more competitive as it relates to hiring physicians. And so you want to retain them on your staff. And so today, some of the strategies we're going to get into are more so related to how can you be efficient with your operations? How can you manage access in a thoughtful way, and in a way that doesn't burn out your providers and staff as you progress. One other point on this is talking about doing more with less. You look at reimbursement and the physician fee schedule itself, just focusing on practices. That number isn't going up, right? Like it's been going down every single year from about 2020 through this year. The fee schedule conversion factor has gone down on 9%. So every year it's 3, 4, 5% less in terms of reimbursement for physicians. And you look at all the physician professional societies and lobbying groups, they're constantly pushing Medicare to change these rules, to, start to consider inflation and other factors and not decrease the fee schedule, but rather try to increase it. And that doesn't seem to be happening. And we don't know if the final rule that comes out in the next few weeks is going to change and be different. But right now they proposed another cut for 2024. And so the volume of patients that a practice is going to need to see in order to be financially sustainable is going to continue to grow. And so something's going to have to give eventually. But for the time being, we need to focus on efficiencies in a practice to remain viable. And so as we get into strategies, wanted to kick it over to Baines to start to outline some of our key focus areas and ways that we want to impart on those listening that you can focus on to make small progress. It doesn't need to be transformational right away, but you can make small progress in certain areas and it can have a big impact on your operations.
Thanks, Andy. As we talk about ways to create a system that maximizes patient access, it's important when you're creating these policies and procedures to get everyone on the same page to understand why the organization is doing this in the first place. When staff members understand the reasoning behind these policies they've created, it generally leads to better results. It helps shift their mindset from task-oriented to outcome-driven. And one way to do this is to involve staff in the process of creating those policies in the first place so that they can keep it top of mind and that they take ownership of it. Also, we like to set goals, set expectations for the staff. It's a great way to increase performance. And I know Kelly will discuss later some of the accountabilities and KPIs, ways that you can measure that progress and success in more detail. Simplifying the scheduling parameters is another great method. We've seen a lot of success with, for example, primary care physicians who utilize super slots that are generic and allow any patient to be seen during that time. Every restriction that you put on your schedule, for example, only doing physicals in the morning and only seeing this type of patient in the afternoon and keeping these slots open for last minute appointments, starts to create layers on layers of barriers to the schedule. And ultimately what usually sees is you end up being able to fit less patients on the page. So having that generic template utilization allows you to really make it easier to get patients on the schedule. Another method is understanding referral patterns to help you manage the process. Identify commonalities or difficult payers so you can address the problems and be more efficient. Physicians generally dislike standardization. They have their own practice patterns and preferences for how they want to see patients, but you can create scheduling protocols that preserve that flexibility and that physician independence without inhibiting patient access. It's important to build a scheduling system that can be learned quickly and performed effectively. If you have issues every time staff are on vacation, or every time staff are out sick, or every time you experience staff turnover, which, as Brent said, is all too often these days, then you should consider taking a critical examination of your scheduling guidelines and find ways to just make it simpler, easier to process, understand, and schedule patients. Kelly, do you want to share some insights around KPIs and ways of developing a system of accountability?
Certainly. Thanks, Baines. So we recommend selecting metrics that cover varying components of patient access. And there are several metrics or key performance indicators that we recommend our clients monitor on a regular basis in order to optimize patient access. And by tracking and trending these metrics and then acting on them accordingly, the practice is able to build a framework for accountability as well as provide the best experience for its patients. So, for example, the process might start with a patient calling the office for an appointment. So we recommend tracking phone or call center metrics. These metrics are typically available through reports from the practice's phone system and include things like the average speed in answering the call, the average time a patient spends on hold, as well as tracking inbound call abandonment rates. And so that's when a patient has been on hold too long and decides to hang up, and so the call is abandoned. So tracking all of those are important. We also recommend tracking the timeliness of patient appointments. And this can be measured by looking at new patient lag days, which looks at the number of days between when an appointment is scheduled and when a patient can be seen. Third next available appointment is also an important measure. And we feel that this is a more sensitive reflection of true appointment availability versus looking only at the next available appointment. And that's because it eliminates chance occurrences of appointment availability due to a cancellation or other unexpected event. So, for example, if a patient calls for an appointment, there happened to be a cancellation that day right before they called and they're given an appointment, it looks like the appointment is able to be obtained quicker. So finally, it's also important to monitor appointment utilization rates. So how many appointment slots were actually used as a percent of the overall slots that were available for use? What are the no-show and cancellation rates as a percent of total scheduled appointments? What percentage of canceled appointments were patient-driven versus those that were practice or physician-driven, known as bumped appointments? And how many of those bumped appointments were lost, perhaps to other providers, when the patient did not reschedule the appointment, versus those where the patient was still impacted, but they agreed to reschedule the appointment? And we feel it's really important to measure the impact of bumped appointments because not only does this impact patient access, it can also impact patient satisfaction as well as staff efficiency. And looking at staff efficiency, we also like to create a calculation that looks at the total number of arrivals, no-shows, canceled and rescheduled appointments to determine the number of staffing touches it took for one completed appointment. And this helps to illustrate the impact that no-shows, cancellation, and bumped appointment rates have on overall staff efficiency. So if this ratio is 2.0, for example, then it took 2 staff touches to complete one patient appointment. So these various metrics should be tracked and trended over time. And a practice can either compare these metrics to industry benchmarks, such as those that are available through MGMA or Medical Group Management Association, or they can establish their own internal threshold targets for each metric. And when metrics are not being met, the practice needs to determine appropriate actions to take, such as implementing mechanisms to reduce no-shows through the use of automated reminder systems or instituting a no-show policy. New patient wait times can be reduced by adding protected slots to the schedule for new patients. And appointment utilization may be improved overall by implementing non-traditional scheduling methodologies, such as advanced access or wave scheduling, that can help address patient access and capacity issues. So I'll now turn it over to Andy and Brant, who will talk about differentiating patient access and operational throughput.
Thanks, Kelly. Yeah, we alluded to this at the beginning that there can be a difference in why an organization will focus on improving patient access. And when you look at it through the lens of performance improvement, it's to avoid vacant slots on our current schedules and to drive demand to your organization over others because it's easier to get in, get scheduled, be seen, be processed as a patient. And with the metrics that Kelly mentioned, some of those can be used to evaluate the actual entry points, the access points for the organization. Others can be used to determine how much capacity and or opportunity we might have to increase volume, increase production without opening additional slots, adding providers, asking providers to work longer hours, et cetera. So what's our capacity in current time and how can we fill it more effectively? And sometimes when we're looking at performance improvement opportunity and estimating the financial benefit of such, we'll look at benchmarking from on the individual provider level at work RVU production, visit production. But another way to look at it is what if everyone below median or all of our providers even saw one more patient per day? What if they saw two more patients per day? Some might have capacity to see 5 or 6 a day, and others might have very little capacity. But if we could just average that out, the one patient a day test is can really be enlightening as it relates to your financial opportunity around patient access, because most providers could average another patient a day with some minor tweaks to schedule templates, to phones, and to a phone agent's ability to put a patient in the schedule in real time versus having to, say, check with a clinical staff member or with the provider themselves. And some of the regulations or rules and constraints that providers have put on their schedules traditionally can become a barrier to filling those slots. And so when you empower frontline staff with the ability to not only make those decisions, but also incentivize them to proactively manage no-shows, cancellations, and reschedules. So they want to see the schedule full, and they'll make a real-time decision to fill a slot within an hour or two of a visit that may have gone vacant otherwise. You can really start to see benefit, but they're not going to do it unless there is data to track it and unless there's a system of accountability, to Kelly's point. And so I think focusing an organization on the patient side of this, right? We're focused on no-shows and cancellations, et cetera. We're focused on third next available, making sure patients have access. They don't have to wait too long to get in. We're focused on our phone stats. Those are patient satisfaction metrics from the patient's perspective. But when you put those out there and put them in the job competencies and the performance metrics that you're going to use to evaluate the staff that perform those functions, it becomes an organizational improvement initiative as much as it does a patient satisfaction initiative. And so that's how we like to connect the two, is we're doing this for the patient. All of this is to get patients in more timely, more efficiently, and to make their lives and our lives easier as it relates to managing their care. But if we do all those things, it also equates to 2 more patients a day per provider over a year, which is worth X amount of additional fee-for-service revenue to our organization. So connecting the dots for the staff so that they understand their role in not just processing patients, but how they're contributing to the financial success of the organization, and where you have the ability, integrating that into their roles and responsibilities and performance reviews and bonus incentives and anything else you can do along those lines can really be a powerful way to light a fire for change, as opposed to just monitoring with data and hoping things improve because we're measuring. So, Andy, on that note, why don't you talk a little bit more about some kind of clarifying roles and responsibilities and how we've seen this be effective with some of our client work?
Thank you, Brent, of course. And so a lot of what we've talked about to this point has been essentially about creating a schedule that has more appointment capacity, or the optimal amount of appointment capacity, right? Do more with less, kind of as we talked about in the beginning. But what we haven't touched on is how do you get those appointments through the practice efficiently? And we've all probably had a restaurant experience where we go somewhere and it's completely full. They've booked all the tables. That's great. They must be doing a wonderful job. But then you sit there for like 3 hours and, you're either waiting too long for your food or too long for your check. The server blames the kitchen, so on and so forth. Well, they were great with their appointment capacity, but they did not get those tables through efficiently, and it led to a really bad experience. You see it in a physician office as well. Wait too long in a waiting room, or you're sitting in the exam room in your gown after the MA throws you in the room, and you wait for 45 minutes for the physician or something of that nature. There are definitely worst case scenarios like that happen in a practice. And that's typically the result of operational throughput not being where it should. A lot of that is driven by the staff. And there's definitely a role of technology. We'll touch on that a little later. But in terms of getting this right, it typically takes everybody in that practice, on the same page with what everybody else is doing, clarity of roles and responsibilities. Sometimes that takes mapping out the process, right? Like from the time the patient walks into the door to the time they check out and leave, who's doing what and why are they doing it? Additionally, it's really important to understand if each person is operating at the top of their licensure. So we mentioned the MA. They're very critical in terms of this process, but are your MAs just rooming the patients and then going to the next patient? That would leave a nurse or a physician to enter orders or information, collect demographics, whatever else it is. That's probably not best for them in terms of their licensure and what they can offer to the team. And so maybe the MA can do a little more. Get an MA, give an injection. That, state by state, that may vary, but you see what I'm saying is each person in the team doing everything they can in terms of their licensure to get the patient through the visit? Or does an MA have to put somebody in a room, then wait for the nurse, then wait for the doctor, and so on and so forth? And so understanding kind of where you stand in terms of your staff's licensure, are they doing everything they can do, and are they collaborating in an efficient way so that by the time the doctor sees the patient, they can be the doctor, right? They're doing the medical decision-making, the assessing, everything of that nature, and getting the patient exactly what they need, but doing it in a timely manner. The other piece to this is handoffs and communication. So I mentioned several different types of staff, right? And so at each point in the visit, an MA is handing off to maybe a nurse or an LPN, or just handing off directly to the doctor. That may go back to the MA, or it may go to the lab. And so understanding those junctures of the visit and how to hand off efficiently, or also how to communicate, where the patient is in the visit, or communicate delays and those kind of things. It's really critical for staff to be communicating effectively there. Sometimes that can be established through the medical record where, somebody puts a patient in a room, they can put the status as roomed, or they can put a status as vitals taken, or whatever it may be. Now, everybody's EMR may not have those same capabilities. They might have them, but they're not great. And so that varies widely, but are you using those to your fullest is a very important consideration. Additionally, are you doing huddles? Very basic thing. But at the beginning of the day, if you've got 50 patients or whatever is a ton of patients on your schedule, it's really critical to get the team together, and not just the MAs or the nurses, but everybody before the clinic starts, and to understand, okay, there's going to be a bottleneck at 10 a.m. or there's going to be a lull in patients between 1 and 2. And so we can do catch-up work during this time. But to map out those kind of critical points of the day and understand, who's doing what then, or what can be done to mitigate certain issues is really important and really helpful. If you're trying to improve this, another thing that's also helpful is to have the physician in the huddle. That's, maybe not always the case, depending on the physician, or if they have to round in the hospital or whatever else beforehand. But encouraging provider participation in the huddles is very important. But if you're trying to improve it, huddle at the beginning of the day and then huddle at the end of the day so that you can understand what went wrong in a given day. What do we need to try differently in the next day? Because those types of rapid improvement activities can really lead to significant gains as it relates to efficiency, because a lot of this is understanding the tools you have, the people you have, and then coming up with your own way and kind of configuring things in a way that allows those patients to flow through seamlessly so that you don't have somebody waiting too long in the waiting room or sitting in their gown for too long or whatever. The last thing you want is that worst case scenario, because in today's, healthcare environment, they'll go on Google and give a bad review, or the Press 80 scores will be really bad, or whatever else it is. And so it exposes you to a lot of other things outside of just inefficiencies, but in general, just poor patient experience. And so this concept of operational throughput is critical as it relates to patient access, because the two kind of go hand in hand, right? Like you can't optimize a schedule, your scheduling capacity and everything like that, but then leave operational throughput or efficiency out of it, because you're essentially going to fall on your face and it's not going to be a successful initiative. And so we need to be considering both of these as we move forward. And I mentioned previously the role of technology. I didn't get into too much of that here because I wanted Kelly and Brant, kind of in this last piece here to discuss, managing and addressing access as it relates to APPs and other providers, but also technology. So Kelly, Brant, I'll let you guys take it from here.
Thanks, Andy. One trend I'd like to highlight is the increasing amount of time it takes for a patient to obtain a physician appointment. A survey conducted by AMN Healthcare in 2022 indicated that the average wait time to schedule a physician appointment across 5 medical specialties in 15 major metropolitan areas increased 24% since 2004. And that was the first year the survey was conducted. The survey found that it now takes an average of 26 days to obtain a new patient-physician appointment for those 5 specialties, which include cardiology, dermatology, orthopedic surgery, obstetrics, gynecology, and family practice. And there are several reasons for this, but one relates to the supply and demand of physicians. And this builds on some of the information that Andy shared previously. And this situation is only predicted to get worse over time as the population grows and ages, which will drive increased demand. And while on the other hand, the supply will decrease based on more physicians that are predicted to leave the profession, as Andy talked about, or reduce work hours due to burnout, as well as physicians nearing retirement age. And one solution to this is to increase patient access involving the use of APPs, including nurse practitioners and physician assistants. And APP care models have been shown to support greater access, expanded patient panels, as well as improved financial performance while helping to address provider supply deficits. And in Coker's experience, for example, we see APPs assigned a physician equivalent of 0.5 to 0.7 FTEs, which means that those APPs can be used to help address provider supply deficits, and one APP can account for 0.5 to 0.7 of a physician FTE. So APP care models can range from APPs maintaining their own panel of patients, which will expand access, to leveraging APPs to enable physicians to see a larger panel of patients. So this could include using APPs to care for patients with chronic diseases, to perform routine follow-ups or handle urgent issues. And all those tasks will allow physicians to manage a larger panel of patients. Other trends we see to improve access include practices adding urgent care or after-hours clinics. And we're seeing this not only for primary care, but also for specialties like orthopedics. We're also seeing a proliferation of technology advancements that can help to improve patient access with some mixed results. And I'll turn it over to Brant, who will share some thoughts on that.
Yeah, there's been kind of a journey here of investing in technologies or solutions to help with patient access. Many of you have probably, whether you know it or not, gone through a patient intake system like a Phreesia. Maybe you've been handed a tablet or gone to a kiosk. That was very popular. I'll estimate around 10 years ago that started coming out as a way to improve patient intake and better manage patients, have them fill out all the forms online before they show up for their visit. All good ideas because of what we used to face with 30 minutes of paperwork once somebody arrives to their appointment 10 minutes late. That was kind of step one. Then we had the advent of patient portals and outbound patient reminders. There are call systems. Many of your organizations are probably utilizing those today. A report we found in preparing for this today said that about 55% of organizations are utilizing patient portals and outbound appointment reminders as a means to improve patient access. To me, that sounds both low and high. I'm surprised that many organizations are not doing those things at this point. But the ones that do have it, in our experience, are rarely leveraging it or getting the most out of them. And part of that is patient adoption, and part of it is system or organization or maybe just provider resistance to meeting the system where it is, right? So the patient portal is only as valuable as the provider entity on the other end is in using it for communication, scheduling, medication refills, all those types of things. If there's no value in the portal, then patients won't use the portal. And so I think that's kind of a basic structure at this point, where if you're not using patient portals or you don't have patient reminders going out in an automated fashion, then that's probably something that you should look into as almost a staple at this point, from my perspective. But just buying one or using one doesn't necessarily ensure success or isn't going to necessarily drive improvement. Only about a third of respondents from the same survey mentioned in this article are using patient self-scheduling tools, and this is a scary one. It's met sometimes with resistance from patients because they're not sure if they're doing it right or the systems are clunky and not easy to use. But typically what I've seen more is that provider schedules are too complex for people who work right next to them to navigate, much less for a patient who's out there searching for a visit type that they're not really sure of. They don't know if they need a 15 or a 30, or if this is a physical, how many problems they have. And so this problem, I think that there is a lot of opportunity for patient self-scheduling to alleviate staffing needs, alleviate phone calls coming into the practice, jamming up lines for phone calls that need to come into the practice. And it makes everyone nervous on the provider side to give up control of those schedules. And I recommend simplifying the schedule so that the control of the schedule is less necessary. That's easier said than done in some specialties and in some areas and some patient demographics. But that generally, I think there are ways to really improve the utilization of self-scheduling by better establishing our scheduling templates, if there are going to be templates, and the protocols for where visits can be put, and starting to let the 40 to 50% of patients who are very capable of doing these types of things take a massive burden off of your practice infrastructure and needs, and then continue to manage your highest need patients, those that don't use technology or that choose not to use technology, and to communicate and relate to the practice. So those are some of the popular strategies that we are seeing a lot of with varying degrees of success. Coming out of COVID and with the buzzwords of AI and augmented staffing and all the other things that we have at our disposal today, even if they're in beta form in some cases, there are all types of new ways for you to advance your patient access technology infrastructure. Telehealth would be probably the most common and most recently adopted by many organizations. We're not going to go deep into telehealth today, but there are a number of ways to conduct virtual visits, and there are billing issues tied to that, and there are a number of things to consider. So you can't just replace volume with telehealth, but I do think we've entered a phase of healthcare delivery where if you're not offering some form of telehealth, again, depending on your specialty or your setup, but if that's something you've chosen to be an ostrich with and just ignore, I think that's going to put you behind, because I think patients are going to start expecting it, just like they expect to have a patient portal or something as basic as that. So on the one hand, that's cutting edge, and then on the other, I think it's going to be the first cutting edge patient access technology that really becomes a staple. We're also seeing a lot more either whether you want to call it AI or just sophisticated analytical engines that drive patient communication without manual human intervention. We had a meeting, this team met with a group recently that can go into patient level data behind the scenes and reach out to the patient on behalf of the practice, looks like practice communication related to annual wellness visits, schedule those visits, drive those visits, manage questions and or information about those visits all through your system, your HR, and it wouldn't require any additional staffing. It can significantly increase volume if you're not doing a good job of managing that today, and you're prompting care that should be prompted anyway based on care protocols, but often is the lowest priority for that front desk person who's managing inbound calls, checking patients in and out, and worried about redoing a schedule for a provider who's taking vacation next week all of a sudden. And so using tools like this, again, that may not be the right solution for your organization or your situation, but I can think of several clients where that would be a really great way to drive additional volume, improve patient access and satisfaction, improve their care protocols, especially if they have any value-based care dollars attached to completing annual wellness visits, and really be an all-around win without burdening their organization's infrastructure any more than it is. So I think this is an area where technologies and solutions are being developed because there's an appetite of organizations to buy them. And I wouldn't recommend buying them just to buy them, but picking the ones that help you most address the issues that you struggle with, and then using those to really intentionally as tools, and adapting your operations as necessary to use those, and not just expecting that every tool will customize itself to what may be an archaic way of managing a physician's schedule or patient phone calls or things like that. So, as you explore that universe, we'd be happy to answer questions. We've seen a lot of them, and there seems to be a new one every day that's working on patient communication and scheduling. Baines, as we get ready to wrap up here, maybe just talk about overall, stepping back from the weeds we've gotten ourselves into here, how we are going to measure success around patient access and what types of strategies and tactics we can be focused on as these organizations try to adopt some of these ideas.
Yeah, as the others have said, patient demand is outpacing provider supply. And so stagnant practices that don't adapt will likely be overwhelmed or incapable of meeting demand. Contrast that to forward-thinking practices that will remain competitive by streamlining patient access, making it easy for patients to schedule, measuring KPIs, and developing simplified internal processes. Those will all go a long way toward creating a high-performing patient access strategy.
Yeah, and this area is kind of nebulous when we work with clients and provide recommendations around patient access. It's the least cookie cutter of solutions because it's more like a list of tactics or a menu that you can pull from and say, this is really going to help this organization because they're struggling with this piece of patient access the most. And so sometimes we'll identify opportunity with patient access at a high level. And then when we get in there, it's really establishing a clear definition of a no-show, putting in place protocols, and managing your chronic offenders with intentionality and proactivity, double booking them, multiple reminders, communication via, written communication via mail to let them know they're going to be managed in this way because of the high number of no-shows. And that can be a whole project in and of itself. But if your no-shows, to Kelly's point earlier, are causing staff or other resources to be doubled or tripled just to manage for the same completed visit volume, then it's worth it, both as cost avoidance and as revenue generation. And so, we want to give some ideas and thoughts here as to the things you can look at and consider. Using data as an underpinning to all of that will be critical for those of you who are managing practices and need to know how to prioritize or evaluate opportunities. And then ultimately, the data has got to be a piece of the accountability as well. And this is not something that you solve tomorrow or this year and then it runs well forever. This is a daily blocking and tackling. It requires daily intensive effort and needs to be a priority for the people who are in the trenches on a daily basis. If the practice manager and the doctors are the only ones concerned with this, you're not going to see change in outcomes the way you want. Like Andy talked about with the huddles, and making this both a pre-game plan and then a post-mortem, post-game. What did we do well? What did we not do well? Let's do better tomorrow, not next year, not next month, but what can we do better tomorrow? What can we do better this afternoon that we failed on this morning? So, I hope this is helpful. We appreciate you all continuing to stick with us through this series. Looking forward to the next series that we'll have out here, or the next episode that we'll have out here soon. And as always, please reach out with any questions or if you have particular areas that you focused on and solutions that have really worked well for you, we'd love to hear about that. We're constantly learning in this space as to what organizations are doing that's effective and what things to avoid. So please reach out, be happy to engage in dialogue whenever you're ready, and have a great rest of the day. Thanks again for listening.
We hope you enjoyed that episode of Coffee with Coker, and we thank you for listening. We want to encourage all of our listeners to participate and contribute in the podcast. So if you have any questions on any of the things we discussed in this episode, any of the topics that were presented, please feel free to ask us. Also, we welcome your feedback and suggestions. If you have any ideas related to the material we discussed in this episode, or in any episode, please let us know and we'll make sure to incorporate it. And if you have ideas for topics you'd like to hear more information about in future episodes, please send those suggestions to us. We would love to hear them and we'd love to incorporate them into our future episodes. You can find us online and on social media. Start with our website, and specifically the podcast is coffeewithcoker.com. You can also find that through the main Coker website at cokergroup.com. You can also find us on social media, Twitter at Coker Group, and then on LinkedIn, you can search for Coker Group and find our page and the page for some of our team members as well there. So you can find us and reach out to us a number of places. And then if you want to contact us directly, one of the best ways to do that, email feedback@cokergroup.com. That's feedback@cokergroup.com. And again, we'd love to get your feedback. And we'd love to encourage everyone to subscribe to the podcast so that you can be notified when future episodes are released. We look forward to the next episode, and we look forward to getting your suggestions and feedback on this episode. Thanks for listening, and we look forward to speaking with you again on future episodes.